So when a child's mouth breathing for a long period of time, it will deactivate that area of the brain. And so myofunctional therapy really focuses on facilitating a closed mouth posture and activating the nasal passages and making sure that the person reaches a more rest and digest or parasympathetic state through nasal breathing to calm their nervous system down. So regardless of what the symptoms are, the intensity will decrease when you do myofunctional therapy, which is foundational because the brain needs oxygen and nitric oxide, most importantly, which is produced in your nose.
Welcome to the Soaring Child podcast, where parents of children with ADHD learn tips and tricks to help their child soar at home, at school, and in life. We feature interviews with experts, medical professionals, and parents just like you who are learning how to reduce ADHD symptoms using food and other natural strategies. Because children with ADHD deserve to soar just like every other child. I'm Dana Kay, your host. Hello, parents. This is Dana Kay here with another edition of the Soaring Child podcast. Today's episode is a special one. It focuses on a therapy that you might not have actually heard of. It might not even be on your radar, but could make a world of difference for your child. And that's Orofacial Myofunctional Therapy. Now, that was a mouthful, but stick with me because it's truly fascinating and could be a game changer for your child's health and for their behavior. Picture this. Okay, your child is struggling with things like breathing and swallowing, or maybe even their behavior, and you're constantly searching for answers. That was me back in the day. Well, that's where Orofacial Myofunctional Therapy comes in. It's kind of like this superhero therapy that sort of combines simple exercises and techniques to help kids with everything from their speech to their eating habits to their behavior. But how do you know if your child could benefit from this therapy? What does a session look like? What is it? And most importantly, how can you as a parent support your child through it? Well, that's what we're going to be talking about today. Our special guest, she's here to answer all of your questions and more. Marielly Mitchell is not only an expert in orofacial myofunctional therapy, man, that's a mouthful, but she is also a doctor of occupational therapy. She's a feeding and swallowing specialist and a sensory processing expert. Her innovative approach to OT centered on orofacial myofunctional therapy, or OMT, let's call it OMT for short, that might be easier, combines principles of cranial nerve integration, sensory processing, and motor function, allowing her to address neurological and airway dysfunction in infants and children that impact behavior. Dr. Marielly is the founder of TheraPlay LA, the first pediatric therapy center to offer comprehensive services that include sleep monitoring in conjunction with virtual and in-clinic occupational, physical, and speech therapy services, specializing in sensory processing, motor skills, feeding and swallowing disorders, OMT, nutritional support, and sleep training. Now, me and Cooper, my dog, who just popped up, would love to welcome Marielly Mitchell to the Soaring Child. Hi, Marielly. How are you? Thank you so much for joining us.
Hi, thank you so much for having me. Your dog's so cute.
He just popped up to say hello. But no, I'm really excited to talk about this topic. It's, as I said, it's a mouthful, and a lot of parents out there would have absolutely no idea what it is. So thank you for coming on and shedding the light on it. Why don't you just start by explaining how orofacial myofunctional therapy helps children with some of those things that I mentioned, like that breathing and that swallowing and even ADHD behavior?
Yeah, absolutely. Yeah. And thank you so much for having me. I'm so excited to be here. This is a topic that is very near and dear to my heart. I have a lot of experience with this as a patient and a practitioner. So my experience with this entire kind of world and niche is very deep. But basically, orofacial myofunctional therapy, which we will refer to as OMT, focuses on the primary focus of it is the position of the tongue and where that person puts their tongue. And ideally, everyone should be placing their tongue suctioned to the roof of their mouth, behind their two front teeth, with their lips sealed and breathing through their nose without tension in their jaw. And a lot of people, as I say that, are going to be listening to me like, where's my tongue? And then they're going to touch their palate and they're like, that feels weird. Why? It's never been there. Or they're going to be like, why am I clenching? And it's because a lot of us do have OMT challenges a lot of the time, because you have to remember that this is a very complex but fragile area of the body that's at the mercy of soft tissue. You don't have a hard femur or a hard tibia here to support things. You have your jawbone, but it's kind of floating. That's why jaws can dislocate really easily. It's latched there, but it can really shift quite easily. You're at the mercy of what your tongue does. And so if your tongue's misbehaving or it's not doing what it's supposed to do, things will be sacrificed. One of the most important things is breathing. So if your child has a low oral rest posture, is what we call it, basically mouth breathing, that automatically puts them in a state of fight or flight. So now their nervous system is at a deficit because they're kind of starting their day dysregulated because they are mouth breathing, which the brain perceives as basically that there's danger, as panting, as gasping. And so that can really derail the nervous system and on a foundational level. And really when that carries over throughout the day, it carries over into sleep, which then there's so many processes that happen at sleep, but also the sleep no longer is as restorative as it should be. And so that compounding on itself over time, days, months, years, etc., really impacts the ability for the brain to function, specifically the frontal cortex, which is associated with ADHD behaviors and things like that. So when a child's mouth breathing for a long period of time, it will deactivate that area of the brain. And so myofunctional therapy really focuses on facilitating a closed mouth posture and activating the nasal passages and making sure that the person reaches a more rest and digest or parasympathetic state through nasal breathing to calm their nervous system down. So regardless of what the symptoms are, the intensity will decrease when you do myofunctional therapy, which is foundational because the brain needs oxygen and nitric oxide, most importantly, which is produced in your nose. So you might be doing ed therapy, OT, speech, all these things. But if you're not really honoring biology and physiology, it's really hard to kind of move into the neurology and psychology of things. That's what I always say about that. And because truly, you have to be as you know, eating well, but you also do breathing well and sleeping well and eliminating. But breathing and sleeping really take a huge toll. And I think that's a really kind of abstract, silent epidemic that we're in with this because people don't really realize it. And the technological advancements that we've had in the past 7 years, and James Nestor's book Breath have really put this on the map. But the Oura rings, the Whoops, the sleep image rings, all those things have really given us more access and validation and reliable scores to show how sleep is so important for this really vulnerable population, because you have to remember their brains are developing. So adults can kind of make it through the day without good sleep, but kids can't.
Yeah, 100%. I talk about that a lot. And I think that one of the analogies that listeners have probably heard me talk about is, baking a pie. I know, just bear with me. But, for our kids, we're trying to bake a pie. That pie doesn't need to be amazing, but it just needs to be a good pie. And there's so many different ingredients in that. We talk about the diet. We talk about the sleep, the exercise, breathing for the brain is one of those. And I think you hit the nail on the head there that, to get that oxygen into the brain, we need to breathe properly. Now, we've spoken a lot on this podcast about breathing and mouth breathing. But I loved your take on it. And I love the idea of teaching our children to where to place their tongue, how to breathe through their nose. It seems like such a simple thing, but I can tell you when you were saying that, I had my tongue searching for the top of my mouth and I was closing my mouth and I was trying to breathe through my nose. So how does sort of a parent know if their child might need orofacial myofunctional therapy? Sorry, I should just say OMT. I actually like the sound of it. The sound of it now, it actually flows quite quickly. But what sort of signs should parents look out for?
Yeah, absolutely. That's a really good question. So a lot of the signs, or one of the main ones, is an open mouth posture. So if what I recommend is parents to look through their videos and their photos of their child. And if you see that your child's mouth is open, and it doesn't have to be open with the tongue hanging out, or that you can even see the tongue, but even if the lips are slightly ajar, that is still mouth breathing. A lot of people kind of think, they're like, no, but it's like his lips are close to close. I'm like, that's not nasal breathing. And so you want to kind of see it for yourself visually. Most of us are visual learners, observing them as well. And if you notice their mouth is kind of open a lot of the time while they're sitting and playing, if they're drooling, that means that their mouth is open. If they have a lot of sinus congestion as well, that means that their nose isn't being able to have air filtration. So they have to breathe through their mouth. And there's this vicious cycle that a lot of kids get in with sensitive noses because they don't want it to be clean because there's, it's constantly inflamed, but you can't, and then you have to clean it, but they don't like it, but they're mouth breathing as a result. So you have to get desensitized that. And for a lot of my neurodivergent population, desensitization is a big part of it, which we can kind of talk about later, but really the signs are really that the mouth is open. There's drooling. There's also challenges with sleep.
Mm-hmm.
Children will often have, I have a sleep screener on my website, but one of my acronyms is oh, bad resting. So some of that acronym stands for open mouth posture, halitosis, which is bad breath, breathing stops at night, aptic episodes, enuresis, bedwetting is another sign that the mouth is open or that they're not getting good restorative sleep, waking up at night, really, really night disturbances or sleep disturbances, crawling into your bed. So these things are often really common, but they're not normal. People should be sleeping throughout the night. And as a society, we've almost normalized it and glamorized it a little bit with oh, I only got 6 hours of sleep and I can function. It's kind of well, I don't know how functional that is in long term.
And especially for our kids, their brains need sleep. They are the neural connections and everything that's happening as they're growing and developing are so critical at this time in their life, even more critical for us. Even more critical than us. And so, if your kid is not sleeping well, that can add to a whole host of problems. And, my son used to suffer from bedwetting. He used to suffer from, he'd fall asleep at the dinner table, and he had a lot of those challenges were happening in the sleep time. He'd be asleep, but he wasn't sleeping and getting that nourishing sleep.
Yeah. And the other side of the coin is your child could be falling asleep, but they can also present as hyperactive because they're tired and wired at that point.
Yep,
so
100%.
Point for a lot of these kids. Teeth grinding is also another one. So that's very common. And that's really the brainstem's attempt to basically do CPR and move the mandible, the jaw forward. And people will say, oh, it's from stress. And really that's kind of a myth at this point. It can be induced by stress, but really it's an airway issue. It's your body's attempt to scream for help. And imagine if you're grinding your teeth all night, it's knitting all night. It's not restorative sleep. Tossing and turning is another sign. There's also the kids will have nightmares and night terrors. And that's because the brain is in fight or flight, and that has no bounds. That sticks with them throughout the day and at night. And so they have just really poor quality sleep, and over time it compounds. And so those are a lot of the signs when they're sleeping. And when they're awake, kids who put a lot of things in their mouth, they're teething, they're biting their nails, they're sucking their t-shirt, they're sucking their hair. They always want a chewy in their mouth. And a lot of the OTs or SLPs that are listening, a lot of people recommend these specific chewies that are one-sided or looks like a dinosaur or a Lego piece, but that's actually facilitating more of an open mouth posture. Now you've given a kid something to chew and they're seeking that input, but their mouth is still really open. So you kind of want to think about what you're giving to put in their mouth and for what reasons. These kids will have feeding challenges a lot of the time, selective eating that aren't just rooted in sensory stuff. So if your teeth don't align and your molars can't bite, tear, and shred because you have an overbite or an underbite, that really makes it harder for you to masticate and chew. And so selective eating, you kind of have to unpack what it could be. It's usually sensory and structural and motor skills, et cetera. But if the wheels of the car aren't straight, you can't really drive it straight, right? So dentition, where it's really crowded, is another sign that's overlooked a lot of the time. So that's something that can, and when the teeth are touching or they're crooked, because you're supposed to have space in between your teeth when you're an infant, until your milk teeth are gone, that means that the jaw is too small. And if the jaw is too small, you can kind of know that the airway is too small. So
wow. So there's a lot of signs there that parents can look out for. You may need to stop and rewind and listen to that again and write them down. But so, if a parent does identify some of these symptoms or identifiers, what are sort of some simple activities or exercises that parents can do at home to really support their child through this, or to help them, or even through the process of getting OMT?
Yeah. So really off the bat, where it starts, as much as we're having a conversation about the mouth and where myo focus is, like, don't forget the other side of the coin is the nose. So the mouth is the floor of the nose. And so nasal hygiene is like one of the first things you want to teach children, and any adult really, is I teach people, like, when you brush your teeth, you clean your nose. And if the nose is stuffy, it can't be cleaned, or it's blocked, the child will automatically mouth breathe. If your child doesn't like having their nose cleaned, you have to work on that. That is like, it's like toothbrushing, and the dentist doesn't tell you, I know they don't like it, but we have to work on that. So if that requires like positive reinforcers or whatever the case may be for your child, like, find a way to intrinsically motivate them. And if you have to do it extrinsically too, I mean, be careful, like, don't end up with like a pony in your kitchen, but like, you want to teach them to care for their body. So I believe in educating children and empowering them through that and teaching them about their body, because we don't make the rules. It's just how nature goes, right? And it's kind of like, you have to clean your nose so you can like breathe through your nose so you don't eat germs all day.
So
right?
how do they clean their nose? What's your normal suggestion?
So I actually have a whole nasal hygiene part on my website, but there's a ton of products that I love there. And so like the Brita nasal booger sucker is great. Yeah. There are also ones that you can use for infants that I use on children that are really great for my sensory kids that are really sensitive. I also teach kids how to make a snot sword, and I use really lukewarm water, and I will literally teach them with tissue to pull their boogers out of their nose, teaching them to blow their nose. You can teach kids because if you're breathing through your mouth all day, you don't know how to blow your nose because there's never air coming in or out. So you can put like a toilet paper roll over their nose with like a pom-pom inside so that they get the visual of when they blow through that tube, the pom-pom moves. Really just getting them to be more their nose be more activated and integrated, touching their nose and just turning it on and teaching them to like tickling it. You have to desensitize it if they're sensitive. That's the first part. And then breathe right strips. There's pediatric breathe right strips. Kids should be wearing those if they, like the kids at our clinic are always having a breathe right strip on. That's part of the deal, right? So that's a simple exercise they could do. And then in the mouth, just working on like tongue clicks, getting that awareness, because your tongue should be suction to the roof of your mouth, right? Without a lot of tension in your face. And so you could put a little bit of like a nut butter up there. You could put like a healthy type of spread and having them just kind of do that. And you always also,
yes, for the listeners out here who aren't seeing on the screen.
But I also should clarify that you really want to get clearance from an ENT before doing these things, because if your child has enlarged adenoids or tonsils, you kind of can't do it's not that you can't, but you really need to be very careful doing myofunctional therapy because you're trying to close their airway, but it's already blocked. So that's a conversation that you need to have with your team, with your therapist, and with your ENT to see how much you can kind of navigate, because you can't close a child's mouth if they have enlarged tonsils. It's just there's no airflow. So
that makes total sense. Thanks for sharing that. So, they get started on doing some of this stuff at home. If they decide they need more help, and go and seek out a doctor like yourself, what should parents sort of expect during sort of a typical OMT session at, say, your practice? And how can parents sort of support their child and educate their child through that process?
Yeah. So typically you'll start with an evaluation with a myofunctional therapist, and my OMT therapists can range from speech therapists to dental hygienists to OTs. OTs are a little bit more rare because the mouth isn't really our focal point, but I just happen to have like a more swallowing background and feeding. So that's where the neuro comes into it. But typically they're going to look at the anatomy of the child's mouth, explain to you like what the tongue's doing, likely look if the cheeks have any tone issues, if there's any misalignment with the jaw. They might do some measurements if the child's like compliant. We don't really get to collect measurements. Our kids are kind of running all over the place, or they're really sensitive. And then they'll kind of see and also screen. They should for like adenoids and tonsils. And if they have any suspicions, refer out to an ENT always. if you as a parent have any suspicion that your child has challenges with or for myofunctional therapy, you should consult with an ENT as well. And you can also just go to the first appointment and be like, hey, like I actually have clearance from an ENT. This is what they said. Or, hey, my child has large adenoids. Like I wanted to talk to somebody. And your myofunctional therapist is really like great sounding board for that to kind of weigh out the options too. And with collaborating with your ENT. So it's nice for them to kind of be involved in that process and kind of be a good sounding board for parents. And then from there, you go into exercises. So it's truly about desensitizing first, like the desensitizing something. So then the face, then you stimulate it and you activate it and you integrate it and you coordinate it. So you're stimulating the nerves that control the muscles of the face. And you have to remember, at least in the special needs world, a lot of my kids have sensory challenges or they have motor planning skill challenges. And so there's a deficit with them feeling their face because they can't see it all the time. So a really good tip is to always do these exercises in front of a mirror with them so they can get some visual feedback. We like to kind of desensitize the face and making sure that they can kind of touch it and exercise and do everything. Because you have to remember, if the tongue has been low, the palate's probably going to be really sensitive because it's not touching up there a lot of the time. So these kids can have a really sensitive gag reflex. That's why they can kind of tend to do that or gag on food really easily or become more selective eaters. Because if a veggie stick will kind of always taste and feel the same, but broccoli, depending on how much it's steamed, will melt and move and all these things and can kind of trigger a gag. And that's not going to feel good to me. So it's a protective mechanism in some ways.
Interesting.
Yeah. And so the sessions will typically start with what I talked about before, nasal hygiene, making sure the nose is clean. And then it's really going to bring like an awareness and teaching the child about their tongue. The tongue has 4 muscles, and teaching the child to like lift their tongue, learn where the spot is, which is what I described earlier of like where you say the letter N and it's behind your 2 front teeth, lifting your tongue to your palate, teaching you about your lips, making your lips touch together, all that kind of stuff. And then working on more coordination of like lifting the tongue, shifting it, moving the tongue side to side, touching your inner cheeks, and really just strengthening in a very biomechanical way the muscles and the coordination of this region of the face, which the most important part from my perspective is the airway piece. Because if your airway is narrow or it's collapsing because of the structural implications of your craniofacial bones, then that and your muscles, that's going to impact your breathing, which impacts your sleep and then impacts your behavior.
Wow, like this is fascinating. And, I think you've opened up the listeners' eyes to this. I think a very, very, very important topic that really, as you said earlier, is kind of like a silent thing. No one talks about it.
No one's talking about it. No one talks about it. I feel like it's kind of like the next gluten thing. There's a couple other things, but I feel like everyone's kind of, and like, I apologize in advance. Once you know this, you can't unsee it.
Yeah.
And so you'll never walk through an airport the same again. And you'll kind of notice these things. Like we give the kids in our clinic, we'll be like, my friend at school mouth breathes. Like they're like 5, and they're learning because for our little boys, we're like, hey, if your mouth is open, you're eating farts, buddy. And they're like, they immediately
I love that.
Right? And like, but they realize that there's all these pathogens and these things in the air and they're eating this viral load. These kids get sick a lot. And then they get allergies and they get like hay fever, then they have asthma and they have all these sleep issues and the behavioral stuff comes in. It's like very patterned what happens. But we're in a silent epidemic of this because especially in this country, which is unfortunate, there's no maternity leave. There's a really, I wish everyone could breastfeed. Women get kind of, after they're pregnant and their baby's born, the ball's kind of dropped and there's not a lot of support for breastfeeding and women have to go back to work. So there's a lot of reliance on bottles and pacifiers. And unfortunately, like those can have a negative impact sometimes on the craniofacial bones. And it's that those oral experiences are the baby's first orthodontic kind of experience. And so they mold around that. And that's just physics. It's no one's fault. Like there's no guilt or there's no shame behind it. Just physics. It's what happens. And unfortunately, it impacts the airway. And so there are ways that we can really, like we work with babies as young as we're using a specific tool, a Munchie, as young as 6 months old to negate what those things do. And they will have one until they go into the dentist for orthodontic intervention, if they even need it. But it's to widen and bring the jaws forward because 80% of the jaws develop by age 6. People don't really realize that because they're like, we'll just wait till they're 13. It's like kind of out of date to do orthodontics that late. We're doing them as young as like when those toddlers get those molars in, if necessary, because it's life-changing for these kids.
Fascinating. And so Can you just share some, I suppose, stories or success stories of, have you watched any children, transform their lives from implementing this, and, what sort of improvements did they see?
Yeah. I mean, we see this like day in, day out. It's kind of like, it's still like amazing to me as a clinician, even though I see it. It's still like every time it happens, I'm like, oh my God, whoa, like this is crazy. But yeah, we had one specific case that the family was living out of state, and then they came into LA for therapy and started working with my entire network of airway-centric providers, ENT, dentists, etc. And we did OT and Myo with this particular child, and he had every diagnosis under the sun: ADHD, ASD, apraxia, sensory processing disorder. I mean, he was scripting, he was like speaking in strictly scripts, but very functionally. And we started doing Myo with him. And as he got expanded with the myofunctional therapy, his sleep started getting better. And like his mom was like amazing with keeping documentation of things and pictures and videos. And within 3 months, his teeth started shifting just from therapy. Then within 6 months with his expansion, he started really sleeping a lot better. And he started making sense. Like he was here. He was commenting on what was happening. He wasn't talking about what he saw on YouTube. He wasn't talking about Paw Patrol. Like he was so present in the moment. And then within like, I would say 15 months, when he got the his expansion and really like kicked in, and we started doing the OT. We were always doing OT and Myo put together. I mean, this child has like just taken off like a rocket. Like he is like cracked wide open. He's like now asking mom like these deep existential questions of like, where did grandma go after she died? Like, what does that mean? These abstract concepts. I mean, his hand-eye coordination fell into place, because you have to remember all of those neurons that everyone is working on, OT, speech, PT, ed therapy, etc. Those are short-term memories that get transferred into long-term memories in sleep. So this child was getting all this therapy prior, but it wasn't sticking. Mom came down because she was like, I'm not seeing any progress anywhere. We're in all these things. I don't see any progress. And I was like, I think he's got these sleep issues. And so this child is now like not in special ed. He is like leading his karate classes of like 20 kids. He's in Boy Scouts. He's now riding a bike without training wheels. He couldn't even sit on a bike when I met him. He has so much energy. He's not tired. He's not falling asleep anywhere. And he's just really like socially also taken off. Like he doesn't have an IEP anymore. And I mean, this child, the mother went to Mayo Clinic, and they were like, you might need to find an aid for him for the rest of his life. That's what she was doing.
We've heard that story over and over again. Yes.
And she's like, I just want to take him over there. Like I still keep in touch with her. And I'm like, yeah, like his life is completely transformed. And that's not even an adenoid and tonsil case. Like we've had multiple children with enlarged adenoids and tonsils. And that surgery for so many kids has been so life-changing. These children, they come into our session and they're so aggressive, biting, hitting, scratching. Our forearms are bloody, and like we're trying to just regulate them, and all these really just trying to bring their nervous system into a little bit more of a state of homeostasis. And I peek in, and I'm like, when they're probably screaming or crying, and I'm like, I think I see tonsils. Like I think I do, and I send them the ENT, and God bless ENTs that really can work with their neurodivergent population, who are kids who can't sit still for the X-ray machine, but they really look. And I encourage all of the pediatricians and ENTs, like really take a look at these kids with the behavioral stuff, because so many of them have this, but no one can get them to sit long enough, and they get their surgery. And that's not like the only part of it.
Yeah.
But you open up the airway, and they start sleeping for 2 or 3 weeks, and they come back and they're like totally regulated, and they can attend. I mean, we've had 4-year-olds tell us like, it doesn't hurt to eat anymore. And I'm like, oh my God, like it hurts to swallow. Like it hurts kids to swallow. Like, of course they want butter pasta, because like everything else feels like sandpaper when your muscles are big.
Well, this is amazing. It's been, fascinating talking to you. I mean, my son was definitely part of what we teach in our program. One aspect of that is that restorative sleep. And in order to do that, you need to make sure that there's nothing being obstructed. And my son was, he would sleepwalk. He would, I probably shouldn't be saying this because he'll be listening to the podcast, but all of these things. And, he had to have his adenoids removed. And for us, that was a game changer in some of the things as well. And he wasn't falling asleep in class anymore. And it was just, his brain was getting what it needed, all that oxygen. And, I just want to thank you for joining me today, sharing this enlightening topic with all of our listeners, your experience and your passion. It definitely shines through. So I really, really appreciate that. Please tell listeners where they can find and follow you online.
Yeah, absolutely. So my company's name is theraplayla.com, and you can go to my website there, and I have a lot of resources for parents, or drmarielly.com. My shop for all of the nasal hygiene, oral hygiene, my favorite products for that is on theraplayla.com, and then also on Dr. Marielly as my Instagram handle. There's a lot of information there, and you can go into my link tree and find my free sleep screener for parents to check. Does my child have more than like 3 of these 12 signs that they might have signs of sleep disordered breathing? And then I kind of give you literally like a piece of paper with all the questions you should ask your ENT. So I really try to make it easy for parents, because this is a really complicated part of the body. Other than like a woman's reproductive system, there's not many other parts of the body that have as many functions, and it's a lot. That's why there's so many cooks in the kitchen. That's why there's ENT, the dentist, the therapist, because we all have our processes of this specific region. And I know it's frustrating, like on the other side of it, but I'm also a patient. So I totally get it, but it is a complicated part of the body, and any guidance that I can provide, I do. So you can find it through my website, through my link tree, on my Instagram, and we'll see it.
Well, Marielly, thank you so much again for joining us today. It's been an absolute pleasure. And there you have it, folks. I hope you found today's episode as enlightening and empowering as I did. Dr. Marielly Mitchell's insights into, let's say it one more time, Orofacial Myofunctional Therapy, or OMT, have certainly opened my eyes to a whole new world of possibilities for our children's well-being. Now, remember, as parents, we're always learning. We're always growing alongside our children, whether it's exploring new therapies like OMT or just finding ways to support our kids through their everyday challenges. And every step we take is a step towards helping them thrive. As always, thank you for tuning into this week's episode of The Soaring Child. Your support means the world to us, and we're here for you every step of the way. I'm Dana Kay, your ADHD health practitioner. Keep on thriving. Thank you for listening to the Soaring Child podcast today. To learn more about how to help your child with ADHD soar using natural strategies, visit our website at adhdthriveinstitute.com and follow us on social media at ADHD Thrive Institute.